My topic is acute pain services and patient-controlled analgesia. Pain definition. International Association for the Study of Pain have described pain as an unpleasant sensory emotional experience associated with actual or potential tissue damage. Acute pain is due to any trauma or any injury or any cancer pain or post-surgical pain. Pain is the fifth vital sign. Acute pain is self-limiting and proportional to the degree of injury sustained. Nociceptor and nerve fibers. Acute pain perception begins with activation of specific sensory nerve terminal called nociceptors. It is found in skin, muscle, joints, bones, organs other than brain. It can be mechanical nociceptors, chemical nociceptors, thermal nociceptors, and polymodal nociceptors. Pain pathway can be first order neuron. It is found in cell bodies of the pseudo-unipolar neurons within the dorsal root ganglion. Second order neuron found in rexid laminae of the spinal cord and brainstem. Third order neuron, cell bodies within the VPL of the thalamus. This transmission to the spinal cord from A delta fibers, it is unmyelinated fibers, fast conduction speed and responsible for fast pain. A delta fibers predominantly terminate in rexid lamina 1 and mainly release the neurotransmitter glutamate. C fibers, it is unmyelinated fibers, slow conduction speed and slow pain. C fibers terminate in rexid laminate 2 called as substantia gelatinosa. It mainly releases the neuro spinal cord. The signal then ascends in the different tracts like spinothalamic tract, spinoreticular tract, and spinomesencephalic tract. Peripheral sensitization, a variety of mediators are released in response to the tissue damage like arachnoidic acid, prostaglandins, histamine, bradykinin, and leukotrienes. Central sensitization is due to NMDA receptors. Changes occur within the spinal cord and brain with enhanced nociceptive transmission and perception. Failure of this state to return to normal is implicated in the development of chronic pain state. Why is effective pain management important? Pain is thought to play a role in the activation of the stress response to the injury. This stimulates catabolic hormone release and increase sympathetic nervous activity, and coagulation may impair immune function. Cardiovascular changes, stimulation of the sympathetic nervous system, increase heart rate, blood pressure, systemic vascular resistance, and this increased workload to increase myocardial oxygen demand leads to myocardial ischemia or infarction. Patients with coronary artery disease are at greater risk of complication. Coagulation, immobility due to pain, increased coagulation can predispose to the thromboembolic complications. Immune system, due to decrease the regional blood flow, may decrease supply to the skin, impair wound healing. And increased level of catabolic hormones can lead to protein breakdown and hyperglycemia, impair wound healing. Psychological factor, development of chronic pain from the acute pain state. The patient will develop psychological pain. Assessment of pain. Main components are pain thorough history and measurement of severity of the treatment response. Pain history, we have to assess the pain character, intensity, location, underlying cause, any associated symptom, any current analgesic use. It should be repeated after treatment has begun to monitor the progress. Measurement of severity of the pain include in children the numerical scale, Wong-Baker Faces Pain Scale, FLACC scale, that is face, leg, activity, cry, and scale, child facial coding scale. In adults, verbal descriptor scale, VDS scale, verbal numerical rating scale, VNRS scale, visual analog scale, VAS scale. Verbal numerical rating scale is most commonly used scale and is easily and quick. Assessment of functional pain. Pain can be assessed with patient active also. A is no limitation, B is mild limitation, and C is significant limitation. Treatment of acute pain. A treatment can be given routes by oral, rectal, intramuscular, intravenous, subcutaneous, transdermal, and transmucosal, like intranasal, sublingual, and buccal. Transmucosal pain is mostly for breakthrough pain. Opioid analgesia. Opiates is a treatment of moderate to severe acute pain. Morphine is the drug of choice. Opiates produce effects by activating both central and peripheral opioid receptors. It can be given IM route, IV route, and subcutaneous route. analgesic drugs. It is IV or ITAL. Mechanism of action of paracetamol, modulation of the serotogenic anti-nociceptive and NMDA antagonist and prostaglandins inhibition. Side effect of management of acute pain. It is an anti-inflammatory, analgesics, antipyretics, and antiplatelet effects. Inhibition of COX enzyme. COX has two forms, and 1 and 2. NSAIDs blocks both the forms. It can be administered via oral, rectal, intravenous, and topical gel also. Adverse effect, it can lead to renal toxicity and GI ulceration and irritation, impact platelet function, and aspirin-induced bronchospasm. NMDA antagonist. NMDA receptors is mainly for central sensitization and neural transmission for the pain. Ketamine is the NMDA antagonist. It is an anesthetic agent and it is an NMDA antagonist. Usually we given with addition to the opioids via oral, IV, subcutaneous, and IM. It provides good analgesia for procedural pain and neuropathic pain. Side effects are hallucination, nightmares, delirium, and agitation. So these effects can usually tempered by the administration of benzodiazepines. Alpha-2 receptor agonist, like clonidine, pain transmission can be inhibited by potentiation subcutaneous, IM or IV. It reduces opioid requirements and provide good analgesia, but side effects are hypotension, brady, sedation, and dry mouth. Nitrous oxide, it has an it is used as Entonox, like a 50-50 mixture of oxygen that delivers sub-anesthetic non-hypoxic mixture. It is an it has a rapid onset and short duration of action. It is ideal for providing labor analgesia, dental surgeries, and short procedure like joint relocation. Anticonvulsants and antidepressants. Tricyclic antidepressants like amitriptyline and SNRIs, venlafaxine and duloxetine. Pregabalin and gabapentin are used to treat neuropathic pain as analgesics given preoperatively. Regional anesthesia, like the spinal anesthesia, epidural anesthesia, peripheral nerve blocks, and catheter, it improves pain scores postoperatively and decrease opioid requirements. Calcitonin, it is the main for calcium homeostasis. It decreases acute pain caused by osteoporotic related vertebral fracture. Also reduces the acute phantom limb pain. Multimodal analgesia, use of more than one class of analgesic drug when treating the pain. It improves pain relief, modulation of drug doses. Common regime we used are opioid analgesics with non-opioid analgesics. Patient-controlled analgesia, it used to treat acute, chronic, post-operative pain and labor pain. Goals to deliver pain relief at patient's preferred dose and administration predetermined bolus dose with the button system. Indication, patient who cannot tolerate oral medication and trauma, any burns and cancer pain, phantom limb pain. Contraindicated, absolute contraindication, patient refusal, infection and burns at the site of injection. Patient no knowledge and not able to understand, any allergic to the drugs. Relative contraindications, chronic renal failure, bleeding disorders, and obstructive sleep apnea, antithrombotic therapy. Administration of the drugs, route via IV, epidural or central line, or peripheral IV cannula, and transdermal delivery. Pumps contains locking device, programming device, patient button, and medication chamber. Medication mainly opiates and local anesthesia. Others can use ketamine, magnesium sulfate, and clonidine. Insert syringe of medication into the pump and set prescribed loading dose, PCA dose, lockout interval, and continuous infusion rate, and 1 and 4 hour limits. Preparation, pre-procedure assessment is very important to assess the cognitive assessment, pain assessment, sedation assessment, and respiration assessment. If patient is on epidural or peripheral nerve catheter, we have to assess neurological assessment. Technique, initial loading dose to attain minimum effective concentration. Bolus dose or demand dose, patient on demand, press the button. Lockout period, dose will not be administered to the patient after bolus. Continuous infusion or rate to maintain the minimum effect concentration. Complications, any pump failure, anti-reflex valves, side effects of the drug used, catheter dislodgement or blockage, patient control analgesia by proxy, other family members dealing with it, sir. That's it, sir.
Okay. Can you read the question again?
Acute pain services and patient control analgesia, sir.
What does that services mean? Services mean you think it's only management of pain?
Multimodal analgesia.
Services means it is a separate unit which has to be organized to deliver the pain relief. Okay.
Okay, sir.
So there's a difference between acute pain management and acute pain management services.
Okay, sir.
It is just like your daycare service, daycare
Okay, sir.
surgery unit.
Yes,
Acute
sir.
pain management, if the word services is included in the question, it means how you will organize a unit or a separate staff pattern for administering pain relief for patients who suffer acute pain, which may be due to surgery, which may be due to trauma. Okay, so in that conditions, that has to be included. I'm sorry. Okay. So, otherwise, your description of each and every drug is very correct for management of acute pain. If the question is only acute pain management, what you have described, the various analgesic agents, the opioids and the dexmedetomidine, all these things are all the pharmacological means of abolishing the acute pain. But when it comes to the question of services, I think this question we have asked in the theory discussion also. One of the questions that I asked in November 23 questions, it was asked acute pain services. So we'll just see how we have to answer from that angle.